So today I'll be talking on this topic called ECPR or CPR and ECMO. So this talk I gave in MCon conference that happened in Bangalore in 2018. So I think I'll just start this talk with this video to see how ECPR happens in real life. You see, this is an automated CPR is happening, and whilst the CPR is happening, cannulation is happening. So needs to make focus on this. So there has to be eCPR. It is expected that we have a automated CPR, and cannulation will keep happening without any corrected CPR. As you see, there is venous cannulation happening. That's the ECMO circuit. Okay, so that's the video just to give you an insight as to how in real life ECMO CPR. So basically there'll be a CPR that will be continuing to happen, and then you will be doing cannulating and then connecting to the ECMO, after which the CPR would be stopping once the cardiac output is achieved. So let's look into the background. So I think the whole CPR work or the ECMO eCPR comes from Australia and few other countries, and a lot of work has happened in Melbourne, in Victoria. So if you look at this particular study, which was done in 222 patients, I think their inclusion was age less than 65 years who developed a VF cardiac arrest. So as you see in this group, I think 68 patients did not have a return of spontaneous circulation, and only 55% had a good return of spontaneous circulation. So in patients who did not have return of spontaneous circulation with CPR were put on ECMO, eCPR. So all these patients, as you see, the 5 of these 68 patients had transport CPR, which means at the site when they had a cardiac arrest, so the CPR was uninterrupted from the site of cardiac arrest until the transport to the hospital, and that is also a very essential component of eCPR. And 63 people died at the scene. So, which means to say that a significant proportion of patients who do not develop return of spontaneous circulation would die if they are not put on ECMO. So, because this was the data preceding the study that they embarked on with the CHEER trial, so which I'll be talking about. So let's look into the data of eCPR from Japan. So this was a study from 2000 to 2012, from Jan 2004 to May 2011. Patients were included. So the median age was 63 years, and 81% of the patients were males. So if you look at the eCPR was done in 86 patients who developed acute coronary syndrome, and intra-arrest percutaneous intervention was done in 71% of these patients. So which means they have had a cardiac arrest, and PCI was done in 71%, and 88% of these patients they had return of spontaneous circulation. So 30 days survival with eCPR was 29%, and 24% of the patients had favorable neurological outcome. So in patients, in at least this, if you have to vouch for this Japanese data, 24% of them have good outcome with eCPR. In otherwise, these patients would have been dead because they wouldn't have had return of spontaneous circulation. So if you look at this worldwide data, which came in Resuscitation Journal in 2017, so if you see from 2003 to 2014, so survival to discharge following ECPR was 29%. So otherwise, these patients would not have survived had they not have been put on ECMO. So, and the comment they make from this journal article is, despite advances in the provision of ECMO care and increasing patient comorbidities, there has been no change in risk adjusted survival over time. So that is the final conclusions they make. So at least if you have to vouch for this global data, there is 29% survival in patients where ROSC, return of spontaneous circulation, was not achieved with CPR, and then they survived to discharge following ECMO. So now we look at this landmark trial that came from Australian group. So this came from the Melbourne group in 2015. So this is on the backdrop of that first slide where I showed around 30% of the patients who do not have return of spontaneous circulation would essentially die. So I think that was the backdrop. So in this chair trial, so they distributed the patients between two groups. So one group was out of hospital cardiac arrest. So there were 11 patients, and this was intra hospital or in hospital cardiac arrest. There were 15 patients, and both these groups did not have return of spontaneous circulation with 30 minutes of CPR, and all these patients had to be less than 70 years to be a part of this study. So they had a good CPR, but they did not have return on spontaneous circulation with 30 minutes of CPR. Then they were initiated on ECMO. So in out of hospital cardiac arrest, all the patients were post VF, ventricular fibrillation, and in hospital cardiac arrest, they were put on ECMO only when they identified a reversible cause. If there is no reversible cause, they were not put. And as you see, I think one of the prerequisite for ECMO is they need to be on an auto CPR. So which means they need to have an auto pulse where there is an automated CPR happening. It should not be manual. So both these groups had a auto CPR with this auto pulse machine, and as part of that protocol, so both groups of patients got cold saline at 40 ml per kg as cold saline as a part of the protocol. So they got 3 liters of cold saline, and this is possibly to achieve uh, hypothermia, because although the evidence of hypothermia is fading, at that point of time they tried to achieve this hypothermia by infusing cold saline at 40 ml per kg. Up to 3 liters they infused, and both groups of patients had hypothermia protocol in place, and they underwent emergency ECMO with reperfusion. So this was VF, so we assume that they were all had acute coronary syndrome. So along with emergency ECMO, they underwent percutaneous intervention. In patients with in-hospital cardiac arrest with reversible cause, they underwent hypothermia, emergency ECMO, and in patients where there was ACS, they did reperfusion, or in patients who had PE, so they treated for PE in this in-hospital cardiac arrest. So the other indications for veno-arterial ECMO is profound accidental hypothermia. So less than 32 degree if they have refractory VF cardiac arrest. So that is an indication where you could consider VA ECMO. Or these are indications. I think in India we've had cases where we have used ECMO for beta blocker overdose or calcium channel blocker overdose or TC overdose. So any drug overdose, if they have a cardiac arrest, I think the only hope we have is with by putting them on ECMO. Otherwise, they would essentially die. So there are some absolute contraindications for ECMO. So if there is a bleeding manifestations or any active bleeding, that is a contraindication. Or if you believe that there is an underlying condition which is non-reversible, so which is like if patient has a cancer or has any progressive condition on the background which will not allow him to improve, I think then you should reconsider putting them on ECMO. Or increased age. So I think any elderly patient you would possibly avoid ECMO, or patient where there is an advanced directive, advanced care plan or end of life situation, you wouldn't subject them to ECMO. I think another specific contraindications here, if you're already having a patient with lactate more than 30, so even you put them on ECMO, I think the chances of survival is very low. And asystole is another reason why you wouldn't put them on ECMO. So it, as you see in CHEER protocol, they had VF cardiac arrest or in-hospital cardiac arrest with a known reversible cause. So if you have a patient with asystole, so you would be dissuaded from putting them on ECMO. Or another important contraindication is where your end tidal CO2 is less than 30, which really shows you that they have very low cardiac output and probably may not do well by putting them on ECMO. So if you look at this algorithm which came from the Canadian group, I think this elucidates all the contraindications. As you see, the inclusion criteria would be age less than 65 with witnessed cardiac arrest, and where CPR is started within 5 minutes after cardiac arrest. And contraindication, as you see, entitled less than 13, lactate more than 13, asystole, or where you have an underlying condition which is non-reversible and has poor prognosis. So these are contraindications. So once you have eliminated all this, then you subject them to ECPR. So I'll just show the video of another on-site auto CPR, because this is very important. So when you have to consider each CPR in patients where they've had a cardiac arrest, they need to be put on auto pulse or auto CPR, and they need to be transported on auto CPR, because what it ensures is the chest compressions are uninterrupted until ECPR or until ECMO is initiated. I think that is the crux of the whole issue. So it's just a video to demonstrate how useful is auto CPR or auto pulse, and then your transportation also becomes effective with uninterrupted CPR. So that's just a video to show. So I think the protocol in cheer trial was, I think as soon as there was a cardiac arrest, there was an emergency call or urgent call that goes on to all the stakeholders or a eCPR team. So what then happens is equipment is immediately available in ICU. So basically in Australia they have this equipment placed. So there is an ECMO team, and this whole equipment is placed within the ICU. As you see, there are cannulas, cold fluid, and the drapes, auto pulse, and prime circuit. So these are all placed in one corner, and as soon as an emergency call is made, all these equipments are moved to the emergency department, and ECMO is initiated. And they're brought to ED by ICU team. So they're all placed in ICU. So ICU receives a call, and patient comes to ER, and all these equipments are moved to emergency department. So the key success of ECMO CPR is each individual's role in emergency has to be well defined. As you see, ED consultant manages airway there. So as soon as patient comes to emergency, if he's not intubated, so he gets intubated by emergency consultant, or if he's intubated, airway and ventilation is managed by emergency department. And the key thing is, as ECPR is happening, I think we cannot shock these patients. So there is absolute contraindication for shocking these patients when there is a effective CPR and a plan to put him on ECMO is happening. And there are two nurses who need to be stationed for this sort of patients. So one nurse is actively documenting all the necessary things that are happening, and there is three intensivists who are present on site when ECMO is initiated. So one intensivist is managing the fluid resuscitation, and one intensivist does the arterial cannulation, another one does the venous cannulation, or one may be doing both cannulation, one is assisting them. And we need to have an echo ultrasound on site to look for vascular access, and most important is to make sure that the guide wires are in place, because there have been complications related to cannulation with arterial shearing that happens, or big hematomas developing due to the guide wires not being in the lumen. And the auto pulse or the auto CPR is managed by a ICU or emergency nurse, and ECMO circuit priming is done by perfusionist or by a nurse in Australia. So this is the protocol. So the key thing is every individual should know what their role is, and they are assigned specific roles, and as soon as a team is activated, each one enacts on the role that they are specified. And there needs to be a physician or a doctor who is observing and who is assisting in the whole thing. So essentially you have two intensivists and one emergency doctor and one additional person as an assistance to oversee and help all this process, and all others should be standing back. So there is no role for any other medical personnel to be part of this whole system or whole process that may be in place. So in the emergency department, as I said, the cannulation of femoral artery and femoral vein happens by an intensivist. So and it is by percutaneous cannulation, and as you see, it happens by two intensivists. And 15 French arterial cannula is used, and for venous 17 French cannulas are used. And always it is mandatory after the cannulation is done. So it has to be done in an ultrasound guidance, and make sure that cannula is in the lumen and the guide wire is in the lumen before these 15 French and 17 French catheters are in place, because there have been instances where retroperitoneal hematomas are formed when there is a shearing of the vessel by the guide wire, and then you cannulate these big vessels. So it is always recommended that you need to use ultrasound before placing these catheters, these big catheters. And as I have reiterated, no defibrillation or CVC cannulation during this whole process, because patients cannot be defibrillated when there is an auto CPR with cannulation happening. So I think we need to have checklists in place to make sure that there is no missing item when this ECPR is being initiated. So a checklist, as you see, there needs to be a checklist that needs to be maintained, so that every item that is utilized while performing ECPR is present, and you don't need to run around looking for them. So what about the VA circuit? So VA circuit looks something like this. So basically you have a venous cannulation, blood flows from the venous circulation into the ECMO circuit to the oxygenator, and then your oxygenator blends the oxygen, removes the carbon dioxide, and the oxygenated blood enters the arterial circulation. And the flow rates are kept at around 3 to 4 liters per minute. And I think so you could consider whether patient would how much oxygen is needed to be infused in the oxygen blender. So I think again a reiteration of how the circuit looks. So basically the venous blood flows from the patient into the VA circuit to the oxygen blender, and it gets enriched with oxygen with carbon dioxide removal, and the oxygenated blood enters into the arterial circulation. So there is a need for putting this distal perfusion catheter. So this is to make sure, because there are 15 French cannula which will be sitting in the arterial catheter, which means the distal perfusion is compromised and they can develop distal ischemia. So distal perfusion catheter is placed so that there is effective distal perfusion that is happening to prevent ischemias, limb ischemias. And sometimes there may be a need for cardiac surgeon to help us by putting this distal perfusion catheter. So again, a pictorial diagram of how the VA circuit looks. So as you see, from the venous circulation, blood is going, and the blood is driven by the pump into the membrane oxygenator, where effective exchange of gases happen. And this membrane oxygenator is fed with oxygen and carbon dioxide removal by the pump, and then the purified blood flows into the arterial circulation. So what are all the complications with ECMO? So there's a whole lot of complications that can arise with ECMO. So there are complications related to the cannulation. So you may have failure to cannulate, and you may cause vessel perforation. I think there is a huge problem with arterial perforations or aortic dissection or retroperitoneal hemorrhage. So as you see, all these cannula complications could be avoided by using ultrasound and making sure the guide wire is in place, and the catheter, even after the catheter is placed, it needs to be ensured that catheter is sitting in the lumen, because if the guide wire has breached an artery, it can lead to huge retroperitoneal or other hematomas. And there can be bleeding from the site of cannulations, and there can be problem with your ECMO pump. So there can be uh, problems with the flow of the arterial limb. So there can be obstruction of the arterial flows, there can be obstruction in the venous flow, and there can be malfunction of the blender. So basically blender is a very important tool where there is a blending of air and oxygen that is happening. So that also can lead to problem, and there can be malfunction of the pump which drives the blood from the venous to the arterial circulation. So these are all some of the problems. And secondary complications, you can have distal limb ischemia if you've not placed a distal catheter. There can be pseudoaneurysm. So there's a lot of hemorrhagic complications. Literally, they can bleed in any organ because you would be using heparin to keep the free flow. So they can have pulmonary hemorrhage, gastrointestinal hemorrhage, cerebrovascular hemorrhage, or systemic. They can go into DIC. And if you are not heparinizing well, they can have thromboembolic problems, they can have cerebrovascular accidents and pulmonary emboli or limb ischemia, or you can have issues with having hypoxic brain damage, or due to inadequate flow in for the kidneys and liver, they can have renal failure, and they can go into literally multi-organ failure due to inadequate flows to different organs. And infections is a huge risk. whilst they are on extracorporeal membrane oxygenation. So they will be, because there are so many tubes attached and there is a extracorporeal flow of the blood, so they are definitely at a risk for infections and sepsis. So once patient is initiated on ECMO, the definitive therapy still has to be achieved, because if the cardiac arrest is due to acute coronary syndrome or MI, so reperfusion has to be done. So they need to be taken to coronary angiogram, any stent, any blockages has to be removed, and then obviously your heart function will be resumed, because the definitive correction of the underlying heart has to be done after subjecting them to ECPR, because your role does not end only with CPR and initiation on ECMO. And after your definitive procedure, if it's a VF arrest, at least now we understand that hypothermia may be out, but at least normothermia has to be maintained, and definitely you should avoid any hyperthermia or fever episodes during ECMO. And after 12 hours, slow rewarming can be achieved if hypothermia has been initiated. So, what was the results of the CHEER trial? And as you see, the out of hospital cardiac arrest, they had 7 patients who were initiated on ECMO, and 3 out of 7 patients survived following ECMO initiation. With the in hospital cardiac arrest, all the 13 patients were initiated on ECMO, 8 patients survived, and so the total percentage survival in this CHEER trial that came from Melbourne group was 55%, which is a very good survival. 11 out of 20 patients survived. Otherwise, all these 11 patients would have, all these 20 patients would have died had they not been initiated on ECMO. So at least we were, I think this study showed that at least more than 50% of the patients could be saved by initiating them on ECMO, who otherwise would not have died, because these were patients who did not have ROSC or return of spontaneous circulation after CPR. So if you look at the international registry data, so this was a data which was published in 2016, which is an ECLS registry support. If you look at the international outcomes, so 40% of the patients survived extracorporeal life support, and 30% of the patients survived to discharge or home. So which is very good. So, so your whole ECMO success rate, if you see the Australian data, the CHEER trial, 55% survived. If you look at the world data, around 30% of the patients survived who otherwise would have died had they not been initiated on ECMO. And if you see the spread of the data, you have around respiratory patients, 84% of them were respiratory, 62% were cardiac patients, and 64% of the total patients were initiated on ECPR. So now coming to the the final crux of the whole issue, what is the cost involved? So if you look at the cost for the Australian study, so the individual patient cost was $250,000, and if you look at length of stay of average length of stay for the ECMO patients was around 10 days in ICU and 10 days in the ward, which amounts to $85,000. So your cumulative cost, if you convert to Indian rupees, it will come to 1 crore 50 lakhs for every patient. So this is as per the Australian data, Australian cost. But I think in India we have to subscribe that we do this at a much lower cost. I think our cost, at least in our organization, it would come to close to 20 to 25 lakhs. So which means in India we do it at a much lesser cost, but this was the cost incurred in Australasian group. But the result is what you see in which has been covered in the media also. So this was in hospital cardiac arrest, which is quoted as 1. So this came in their media, and this was in hospital cardiac arrest 11. So Jenny thanks miracle workers who saved her life. This came in Herald Sunday in Australia. So the take home message is I think every large city should have ECPR available. So which means there should be some hope for 30% of the patients who would survive despite not getting or not achieving ROSC even after effective CPR. So I think in our city, in Bangalore city, we have Narayana Hrudyalaya, I think, which does good amount of ECMOs. So I think they should focus more on publishing their data. And what it means is if you are running a ECPR program, it is imperative that you need to have CPR transport, which means you need to have an auto pulse or automated CPR so that there is an uninterrupted CPR that happens from the site of the cardiac arrest until the ECMO is initiated. I think that remains an essence, because if you're doing manual CPR, I think your outcomes would again be affected because your CPR would not have been effective in transport. And as I mentioned, I think it is having the whole SOP, standardized operating process, to be in place, and every individual should be assigned about their task and they need to act upon as ECMO is being initiated. And as I suggested, I think as per their protocol, I think every patient got this resuscitation with cold fluid at 40 ml per kg. So what it means is, although you may be doing good CPR and initiating on ECMO, so concurrent fluid resuscitation appropriately has to be done, and at least normothermia and hyperthermia has to be avoided, and normothermia has to be maintained. So good neurological outcomes have been achieved even with 125 minutes of CPR after they have been initiated on ECMO, which means the neurological recovery has also been very good when ECMO has been initiated, at least from the data that we have. And as you see, 55% of the patients had good outcome at Alfred's Hospital in Australia. And if you watch for the worldwide data, at least 30% of the patients were discharged home with a reasonably good neurological recovery. So thank you very much. So I would end this slide. So how do we improve survival in hospital? So it is about leadership, and more than leadership, it is to do with the teamwork. So I would end with this quote. So minds are like parachute; they function better when they're open. So we have to open up our minds for this ECPR and try to have at least one or two good centers in each city where good ECPR could be initiated. So thank you very much.